Good afternoon. I want to thank the organizing committee for the opportunity to take part in this educational session on local therapy management of the axilla. Today I have the privilege of talking about axillary management in upfront surgery. Is this local control, staging, or both? And I have no disclosures. So I wanted to start off by exploring the evolution of axillary surgery in clinically node-negative patients, as well as address some of the controversies that we see in modern practice. Namely, what to do with sentinel lymph node positive patients that are undergoing mastectomy as opposed to breast conservation. Is routine sentinel lymph node biopsy warranted in all clinically node negative patients? And how should we address the clinically node negative patient by physical examination who comes to us with a report that indicates they have suspicious axillary lymph nodes on ultrasound? So to start off by examining the evolution of axillary surgery and how it has contributed to local control and staging in clinically node-negative patients, we really need to go back 50 years ago to 1971, which was a time when the Halsted radical mastectomy was the established and standard operation for both early and advanced stage breast cancer. And at that time, you had very brave surgeons in the UK and North America who really challenged the pervading thought with the NSABP B4 and King's Cambridge trials. The larger of the two, the NSABP B4 trial, was designed to determine whether local regional treatments other than mastectomy afforded us similar outcomes to those attained with the Halsted radical mastectomy. The trial included both clinically node-negative and node-positive patients by physical examination. And in the clinically node-negative patients who I'm showing here, they were randomized to one of these three treatment arms, but importantly, no adjuvant systemic therapy was allowed or administered. So this was a purely local therapy de-escalation trial. And if we think about separating local management of the breast from the axilla, we see that from an axillary management perspective, this trial was really randomizing women to axillary lymph node dissection versus axillary radiation versus axillary observation. We also know that in the clinically node-negative women who underwent axillary node dissection, 40% had positive lymph nodes. So due to adequate randomization and matching of both measured and unmeasured variables, we can safely estimate that positive lymph nodes were left in situ in 40% of women who were randomized to the other treatment groups. And yet, after 25 years of follow-up, we know that axillary management had no effect on distant disease-free or overall survival in clinically node-negative patients. We did, however, see that in the axillary observation alone group, approximately 18% developed clinically evident progression of untreated lymph nodes compared to excellent and effective axillary control rates in the axillary clearance and axillary radiation groups. Yet because only axillary lymph node dissection provided the means to accurately stage the axilla, which was becoming more and more important because systemic therapy decisions were now being made on the basis of this information, axillary lymph node dissection really became the standard management going forward for the next 2 decades. And that was until the 1990s when the use of sentinel lymph node biopsy presented an opportunity to avoid the morbidity of an axillary dissection in a large proportion of patients while still providing pathologic staging information to guide adjuvant treatment decisions. So we had the Milan and NSABP B32 validation trials, which randomized clinically node-negative women to sentinel lymph node biopsy with immediate axillary lymph node dissection versus sentinel lymph node biopsy with axillary lymph node dissection only if their sentinel lymph node was positive. And from these trials, we learned that A, sentinel lymph node biopsy was accurate to stage the axilla with a low false negative rate of less than 10%. And B, in 70% of clinically node-negative women, there was also negative sentinel nodes. And in these patients, no further axillary surgery was required because survival was unaffected, and we saw very effective local control with axillary recurrences as first events seen in fewer than 0.5% of patients in both arms of these studies. And so what about the clinically node-negative patient with a positive sentinel lymph node? Well, we knew from the node dissection arm of B32 that in over 60% of cases, the sentinel lymph node was the only positive lymph node identified. And this led many to believe that axillary lymph node dissection may be overtreatment in those with low volume nodal disease. And so then we saw the initiation of the IBCSG 2301 and now AATRM trials. These trials randomized clinically node-negative women with micrometastatic disease identified on the sentinel lymph node to completion axillary lymph node dissection versus axillary observation. And what we know from the dissection arm of these trials is that 13% of patients had additional positive lymph nodes that would have been left in the intact axilla in those randomized to the observation arm. Yet oncologic outcomes were unaffected, with no difference in disease-free or overall survival at 10 years, and very effective local control with axillary recurrences of 1% or less. If we then move forward to trials including both micro and macrometastatic disease, these are trials that we are all very familiar with, the ACASOG Z11, AMAROS, and OTISAR studies. We see that in clinical T1, T2 node-negative cancers with up to 2 sentinel lymph nodes containing macrometastases, that women do not really need axillary lymph node dissection in most cases, despite additional positive lymph nodes being left behind in approximately 1/3 of patients. So this was true in those treated with breast conservation on Z11, where we saw no difference in disease-free or overall survival and very low axillary recurrences at 10 years. And in those treated with axillary lymph node dissection versus axillary radiation in AMAROS, again, no difference in disease-free or overall survival at 5 years with very effective local control in the axilla. And so I think take-home points across all of the published and recently presented studies of clinically node-negative patients undergoing upfront surgery, we see very effective local control in those with sentinel lymph node positive disease, with less than 2% risk of axillary recurrences across all studies, including those with mature follow-up out to 10 years. And so I think we are very comfortable in stating that in clinically node-negative patients undergoing upfront breast conservation with up to 2 sentinel lymph nodes positive, sentinel lymph node biopsy affords us accurate staging and is associated with effective local control. So what is the controversy with mastectomy patients? Well, in theory, these patients have more extensive multicentric disease and do not receive incidental radiation to the level 1 axilla that occurs in the majority of breast conservation patients undergoing whole breast radiotherapy. These patients were also less well represented in clinical trials published to date, which included mastectomy patients in 9 to 17% of their study cohorts. It's also very important to note that published trials that included mastectomy patients with micrometastatic disease randomized women to axillary lymph node dissection versus axillary observation, where published trials including up to 1 to 2 macrometastases in the sentinel lymph nodes of patients undergoing mastectomy compared axillary lymph node dissection to axillary radiation. And so based off of currently published studies in clinically node-negative patients undergoing upfront mastectomy who have micrometastases in their sentinel lymph nodes, we have data to support that no further axillary treatment is necessary. Whereas in mastectomy patients with macrometastases, level 1 data currently suggests that axillary radiotherapy is needed to provide effective local control, specifically in those for whom post-mastectomy radiotherapy is planned or indicated. Of course, axillary lymph node dissection can always be reserved for patients for whom PMRT is contraindicated or not required. And we await the results of several additional randomized trials that have restricted their cohorts to patients with macrometastases only, the CINODAR-1, CINEMAC, and POSNOC trial. These trials are expected to include mastectomy patients in up to 1/3 of their cohorts based off preliminary data we've seen. And we look forward with interest to seeing data around post-mastectomy radiotherapy received in the mastectomy population of these trials, some of which will be presented later at this meeting. We do know that over the next 5 years, we should also have the results from the POSNOC trial from the UK, New Zealand, and Australia. This trial successfully randomized 1,900 patients with up to 2 macrometastases identified on their sentinel lymph nodes to adjuvant systemic therapy alone versus systemic therapy with directed axillary therapy in the form of axillary lymph node dissection or axillary radiotherapy to determine whether axillary treatment is really required for axillary control in the modern era with the use of modern systemic therapies. In North America, we also have the TAILOR-RT trial, which is a trial that uniquely examines women with biomarker low-risk estrogen receptor positive HER2 negative breast cancer, defined as an oncotype score of less than or equal to 25. So there will be patients in this study treated with mastectomy and sentinel lymph node biopsy alone with up to 2 macrometastases who will be randomized to no post-mastectomy radiotherapy versus PMRT with regional nodal irradiation with breast cancer recurrence-free interval as the primary endpoint. So I think both of these and the aforementioned trials should help us to resolve whether axillary observation following a positive sentinel lymph node with macrometastases is reasonable for our mastectomy population. And I think these efforts to attempt to identify low-risk patients based on the results of genomic assays really force us to question whether we can further de-escalate axillary management in clinically node-negative patients undergoing upfront mastectomy. Is axillary staging really truly necessary for refining adjuvant therapy recommendations? And without it, is local control compromised? So to answer that first question, I think it's important to address which clinically node-negative patients are being selected for upfront surgery in the modern era. Certainly, stage 2 and 3 triple-negative and HER2-positive patients are preferentially treated with neoadjuvant chemotherapy. So upfront surgery is really reserved for small T1 triple-negative and HER2-positive patients, with the majority of T1 and T2 ER-positive HER2-negative cancers. And so whether a positive sentinel lymph node would alter management in clinically node-negative women undergoing upfront breast conservation, I think it's really contingent on biologic subtype. Certainly in small triple-negative breast cancers, the presence of a positive sentinel lymph node would alter adjuvant chemotherapy decisions, as well as candidacy for olaparib in BRCA-associated triple-negative disease, and potentially local therapy decisions around regional nodal irradiation. The same is true for HER2-positive breast cancers that were planned for upfront surgery with the goal of getting them to adjuvant paclitaxel Herceptin. These patients would now be recommended different chemotherapy regimens with dual HER2-directed therapy, as well as potentially regional nodal irradiation. And in the premenopausal ER-positive patients with node-positive disease on sentinel lymph nodes, certainly we would consider adjuvant chemotherapy and/or ovarian suppression. The duration of endocrine therapy may also change, as well as decisions around regional nodal irradiation. And so I think this leaves one subgroup for which we have the greatest potential to de-escalate axillary surgery, the postmenopausal ER-positive HER2-negative patients, particularly given data from our exponder presented this year and last, where we know that the presence of a positive sentinel lymph node is unlikely to affect most systemic therapy decisions in those with pathologic N1 disease. And so in those select postmenopausal ER-positive HER2-negative patients, can sentinel lymph node biopsy be safely omitted without missing those pathologic N2 patients, and is local control compromised? So interestingly, this question has already largely been addressed in older postmenopausal women with early-stage estrogen receptor-positive disease with the CALGB 9343 trial and the INT trial from Martelli and colleagues back in the 1990s. The CALGB 9343 trial randomized women over the age of 70 with stage 1 clinically node-negative estrogen receptor-positive breast cancer who were undergoing breast conservation to adjuvant tamoxifen for 5 years, or adjuvant radiation followed by tamoxifen for 5 years, and showed us that there was no difference in overall survival, but an improvement in 10-year local regional recurrences from 10 to 2% with the addition of adjuvant radiation. Interestingly, in this trial, axillary lymph node dissection, which was the standard of care at the time, was allowed but was not encouraged. So the majority of women did not, in fact, undergo axillary lymph node dissection. And in those women, we saw very effective local control without axillary surgical staging, ranging from 3% in the tamoxifen-only arm down to 0% in women who underwent adjuvant radiation with tamoxifen. And so I think these trials and those more recent really laid the groundwork for ongoing studies exploring omission of sentinel lymph node biopsy in patients with a negative axillary ultrasound, the SOUND in SEMA, Dutch BOOG 2013-08 trial, and the Nautilus study. And the rationale behind these trials is that we know from Z11 that there is no therapeutic advantage to performing a completion axillary lymph node dissection in sentinel lymph node positive patients with low volume nodal disease undergoing breast conservation. We also know that the sensitivity of preoperative axillary ultrasound combined with core needle biopsy is good at 80%, and that negative axillary ultrasound will exclude the presence of N2 and 3 disease with a negative predictive value upwards of 93%. And so we have the Italian SOUND trial, which is examining unifocal clinical T1 and 0 breast cancers with a negative axillary ultrasound and randomizing them to sentinel lymph node staging versus no axillary staging with primary endpoint of distant disease-free survival. but also important secondary endpoints that include axillary recurrences, quality of life, and physical arm functioning according to the validated quick dash instrument, and the type of adjuvant treatment administered to determine whether those decisions can be made on the basis of the biology of the tumor alone without the prognostic information gleaned from the sentinel lymph node biopsy. We also have preliminary results from the first 1,000 patients enrolled on the INSEMA trial, which is similar to SOUND but includes both T1 and T2 patients. These data suggest that the majority of women enrolled on this trial are postmenopausal, with 90% having T1 grade 1 to 2 tumors, and almost all are estrogen receptor positive. But if we look at the nodal pathology results in the 800 patients in this analysis who underwent sentinel lymph node, we see that 83% were node negative, while 17% were node positive, but only 0.4% had pathologic N2 disease. So overall, only 1.3% of these patients would have not met criteria for Z11 due to the presence of 3 or more macrometastases, provided that there was no gross extranodal extension in these patients. So I think we look forward to the patient-reported outcomes from this study that will be reported later in this meeting, and certainly the long-term outcomes from this study as well. So now switching gears from those who are clinically node negative with a negative axillary ultrasound to those who are clinically node negative but instead have a suspicious node identified on axillary imaging only. And I think that we have all struggled with these cases, particularly women who would have otherwise been candidates for Z11, because historically these patients have been triaged either towards upfront surgery with axillary lymph node dissection versus neoadjuvant chemotherapy in an attempt to downstage the axilla. But we know that not all axillary disease benefits from neoadjuvant chemotherapy in the same way, and that nodal PCR is largely dependent on subtype, ranging from 22% in ER-positive, HER2-negative patients to upwards of 65% in ER-negative, HER2-positive disease. And so I think here biology certainly matters. In triple negative and HER2 positive patients, we know they have a higher likelihood of axillary pathologic complete response with neoadjuvant chemotherapy, and in turn, a lower need for axillary lymph node dissection. We also know that we benefit and derive additional information from the risk stratification of these patients based on whether or not they attained a pathologic complete response to aid in adjuvant systemic therapy decisions, whereas in contrast, ER-positive, HER2-negative patients have a lower likelihood of axillary pathologic complete response, and based on institutional data from Paluski and colleagues, we know that they have a 3-fold higher rate of axillary lymph node dissection in the post-neoadjuvant chemotherapy setting compared to those undergoing upfront surgery. And so with this in mind, at our institution, when encountering the scenario of a patient who is clinically node negative by physical examination but has suspicious lymph nodes on imaging, the first thing we consider is biologic subtype. In those who are triple negative or HER2 positive, they undergo nodal biopsy with clip placement, and if nodal disease is confirmed, we will triage them towards neoadjuvant chemotherapy. Whereas in contrast, in those ER-positive, HER2-negative patients, we know they're less likely to benefit from neoadjuvant chemotherapy, so we will evaluate the number of abnormal lymph nodes, then biopsy and clip the most suspicious lymph nodes. And if only 1 to 2 lymph nodes are suspicious, we are performing a targeted axillary dissection in the upfront surgical setting as part of a prospective single-arm registry trial led by one of my colleagues, Dr. J.F. Boileau. Whereas in patients with 3 or more suspicious lymph nodes that are not eligible, we take them either to the OR for an axillary lymph node dissection or triage them towards neoadjuvant systemic therapy on the basis of clinical pathologic factors and sometimes genomic assay results. I do think it is important to keep in mind that patients with suspicious lymph nodes on imaging do have a much higher likelihood of significant nodal disease burden. We know from institutional series from MD Anderson, Memorial, and Mayo that if only one abnormal node is identified on imaging, then around 60% of these patients will have up to 2 lymph nodes positive on final pathology, whereas 2 or more lymph nodes, if they're identified as abnormal, only 30% of these patients will be spared directed axillary treatment and axillary dissection. So I think that's important to talk about with our patients as we go into the OR. I just wanted to mention that there are other ongoing studies, including similar cohorts of patients, including the multi-center Taxus trial in Europe, which includes an upfront surgery population of women who are node positive by clinical examination or by imaging for randomization to tailored axillary surgery with or without axillary lymph node dissection. Tailored axillary surgery is a novel approach that includes selective removal of all palpable lymph nodes as well as dual tracer sentinel lymph node biopsy and removal of the biopsy-proven positive lymph node that was clipped and either localized or confirmed on intraoperative X-ray. So I think it'll be very interesting to see whether this approach offers similar survival outcomes but less morbidity than the traditional level 1 and 2 axillary lymph node dissection. So in summary, sentinel lymph node biopsy remains the standard of care for axillary staging in clinically node-negative patients undergoing upfront surgery. In breast conservation, we know that sentinel lymph node biopsy is associated with excellent local control when up to 2 sentinel lymph nodes are positive with micro or macro metastases, whereas in the mastectomy population, for those with macrometastatic sentinel lymph nodes, axillary radiotherapy is effective as an alternative to axillary lymph node dissection while we await ongoing trials that are evaluating whether observation alone is feasible. With respect to staging, we know that the sentinel lymph node biopsy continues to impact systemic and local therapy decisions, particularly in triple negative and HER2 positive breast cancer, as well as those with premenopausal hormone receptor positive disease. Whereas in postmenopausal ER positive patients, specifically those undergoing breast conservation, negative axillary imaging may circumvent the need for sentinel lymph node staging in the future. And for the clinically node-negative patient by physical examination who is ER positive and HER2 negative and has 1 to 2 suspicious lymph nodes on imaging but is otherwise a candidate for Z11, I think upfront surgery with sentinel lymph node biopsy can be considered. Thank you and looking forward to the discussion.